Hello, and welcome back to the Deep Dive.
Hello.
Today, we are doing something, I think, incredibly specific, and because of that, incredibly high value.
We're narrowing the focus.
We really are. We're sort of shifting gears from our usual broad explorations, and we're entering a simulation.
I like that, a simulation.
Yeah, we're putting on our study hats, we're walking into the exam hall, and we are tackling a topic that is, absolute gold for examiners.
It's a classic for a reason.
It is. We are placing you, the listener, directly in the shoes of a postgraduate student. Maybe you're a resident. Maybe you are actively prepping for your MD anesthesiology exams. And we're specifically keeping in mind the rigorous standards of institutions like Gujarat University.
Right, so this is for the person with the textbook open, the highlighter in their hand, staring at a very specific question.
That's exactly who we're talking to today. The scenario we're tackling is the one that, well, it probably keeps a lot of residents awake at night.
It does. We're covering the anesthetic management of open globe injury and squint surgery.
And this is a beast of a topic. It's not straightforward. So we've pulled together a massive stack of resources for this.
The usual suspects.
The heavy hitters, for sure. We've got Miller's Anesthesia, Morgan and Mikhail, Yao and Artuzio, and then a whole collection of, clinical manuals and those tricky question banks.
And our mission, our goal for this deep dive is to synthesize all of that. All those pages of dense text into a comprehensive audio guide.
Exactly. We want to help you answer that dreaded 20-mark question.
Or navigate that tricky Viva station.
Without breaking a sweat. Or, well, with maybe a little less sweat.
It's a classic exam topic because it tests everything. It really does. It's not just about knowing one drug. It tests your knowledge of fundamental physiology.
Right.
Your grasp of pharmacology, your hands-on airway skills, and maybe most importantly, your ability to make split-second decisions when two potentially life-threatening goals are in direct conflict.
That's the key, isn't it? The conflict.
It is. This topic truly separates the novices from the consultants. It shows an examiner you can think under pressure.
And the beauty of this topic, and why I think it works so well for a deep dive, is the contrast. It's a tale of two surgeries.
Absolutely. Two poles of the same specialty.
You have two procedures here that represent the absolute extremes of ophthalmic anesthesia. On one side, you've got the open globe injury.
The nightmare scenario. The 3 a.m. emergency call.
Right. And then, on the complete other side of the spectrum, you have squint surgery.
Which looks so innocent on the surface. It's elective, it's often pediatric, healthy kids. But it's actually a physiological minefield.
A minefield, that's a good way to put it. So the structure for today is going to be very deliberate. We're not just chatting.
No, this is structured for success. We are going to follow a 5-part roadmap that mirrors exactly how you should structure your exam answer.
Okay, so let's lay that roadmap out for everyone listening. Part A, which we're in now, is our introduction and exam framing.
Setting the stage.
Part B is the heavy lifting. That's the open globe injury, the emergency section.
All the drama.
Part C is squint surgery, the elective pediatric challenge.
The deceptive one.
Part D will cover the complications for both. And then Part E, which is maybe the most important for exam prep, is the synthesis.
The comparison table, the Viva traps, bringing it all together.
That's the plan.
And I'll say this now. If you write your exam answer with those 5 headings, you are already halfway to a distinction. Structure is everything.
Okay, brilliant. So let's officially jump into Part A, introduction and exam framing. Why is this such a critical topic? I mean, eye surgery is common, but why does it get a 20-mark slot in a general anesthesia exam?
It really comes down to the unique nature of the eye itself. You have to understand that in ophthalmic anesthesia, you're working in what seems like a small remote field, just the eye. But the repercussions of your anesthetic choices are systemic.
And potentially life-threatening.
And potentially life-threatening, exactly. The eye isn't just an isolated ball of jelly. It's intricately connected to the central nervous system. It has these profound, powerful reflex arcs, and it is incredibly sensitive to pressure changes.
So it's that small remote field versus the life-threatening reflexes.
That's the perfect summary. And for your exam introduction, you need to highlight that dichotomy, that contrast.
Okay.
The open globe is all about the conflict between a full stomach, the aspiration risk, and an open eye, the extrusion risk.
And squint surgery.
Squint surgery is the conflict between the surgical manipulation itself and cardiac stability. That's the oculocardiac reflex. It's a completely different set of worries.
And these questions, they often appear as the long questions, right? We're not talking short notes here.
Usually, yes. A typical long question might be, Discuss the anesthetic management of a 30-year-old male with a perforating eye injury following a road traffic accident. That could be 20 marks.
A whole essay.
Or for a short note, something more focused, like describe the pathophysiology and management of the oculocardiac reflex. 5 marks.
And in the Viva, the oral exam.
Ah, the Viva! That's where they hit you with the scenario. The classic opener is, Doctor, you're called to the ER. How do you induce a patient with an open eye who just ate a full meal?
That's the money shot right there. That's the question that makes your heart sink.
It is. But we are going to make sure that by the end of this hour, everyone listening can answer that question with total confidence.
Sounds like a plan.
Absolutely.
All right, let's move into the core of it then. Part B, open globe injury, the ophthalmic emergency. We have to start with the absolute basics. What exactly constitutes an open globe?
This is absolutely essential. Your definition needs to be precise. Based on sources like Morgan and Mikhail, an open globe injury is defined as a full-thickness wound of the eye wall.
The eye wall being the cornea and sclera.
The cornea and the sclera, correct. The tough, white outer layer. If that wall is breached, whether it's a laceration from a knife, a rupture from a blunt blow, or a perforation from a tiny piece of metal, you have an open globe.
The integrity of the eye is broken.
The integrity is broken. That's key.
And why is this an anesthetic emergency? I mean, it's obviously a surgical emergency to save vision, but why the panic for us?
It's an emergency because of the physics of the situation. To understand the anesthesia, you almost have to understand the Monroe-Kelly doctrine as it applies to the eye.
Okay, so the idea of a fixed box with non-compressible contents.
Exactly. The globe is a hollow sphere with rigid walls. It is, for all intents and purposes, a non-compliant compartment.
Non-compliant meaning it doesn't stretch, it doesn't give.
Correct. It can't accommodate extra volume. So under normal circumstances, you have an intraocular pressure, or IOP, of about 10 to 20 millimeters of mercury. Miller gives the specific value of 16 plus or minus 5.
Okay.
And that pressure is maintained by a really delicate balance of aqueous humor production and drainage, and crucially for us, the choroidal blood volume.
And the choroid is the vascular layer, right? The layer with all the blood vessels.
Yes, and this is the absolute key for the anesthetist. You have to picture the choroid. It's a meshwork of blood vessels. It's essentially a sponge filled with blood that sits just inside the sclera.
A sponge. I like that analogy.
And unlike the brain, which has brilliant autoregulation, the choroid has very poor autoregulation. It's very passive.
What does that mean, practically?
It means if your systemic venous pressure rises, let's say you cough, or you strain against the ventilator, or you're put in a steep head-down position, the choroidal veins swell up instantly. That sponge just fills with blood.
And because the eye is rigid, that swelling has nowhere to go. It has to take up space.
It has to take up space. In a closed, intact eye, that swelling just raises the pressure inside. It increases the IOP.
But in an open globe?
In an open globe, the entire game changes. The integrity of that rigid box is breached. The moment that happens, the pressure inside the eye instantly drops to equal the atmospheric pressure.
Okay, so the pressure gradient is gone.
The containment is gone. There's no longer a pressurized system.
Yeah.
Now, the only thing keeping the delicate contents, the iris, the lens, the vitreous humor inside the eye, is the lack of a pressure gradient pushing them out.
So if we do anything...
If you do anything at all, that raises the pressure inside that eye relative to the atmosphere, you risk extrusion.
Extrusion. The word itself sounds horrific.
It is. It is the single worst outcome. The contents of the eye are literally squeezed out through the wound. And once the vitreous is gone, it's gone. You cannot put it back.
And that means?
We are talking about permanent, irreversible blindness.
So this all leads directly into our next section. If I'm writing my anesthetic goals section in the exam section 3 of our outline, what's the checklist? What are the bullet points?
You need 4 crystal clear bullet points here. This is what I call exam gold.
Okay, lay them on me.
Goal number 1, the absolute holy grail of this anesthetic. Prevent any rise in IOP. Your entire plan revolves around this. You must prevent extrusion.
Number 1, got it.
Goal number 2, rapid, secure airway. Don't ever forget this. These are trauma patients. We must assume a full stomach. We cannot risk aspiration pneumonia.
So protect the eye, protect the lungs.
Exactly. Goal number 3, smooth induction. You cannot have the patient fighting the mask, holding their breath, or fasciculating. Any of that is a disaster.
And number 4.
Goal number 4, deep anesthesia and akinesia. Once the tube is in, the eye must be absolutely still for the surgeon to perform microsurgery and repair it. no movement.
But there's a massive glaring conflict here, isn't there? Between goal 1 and goal 2.
That's it. You've hit it. That is the entire crux of the exam question. The reason this is a 20-mark question and not a 2-mark question is that conflict.
Explain that conflict.
To protect the airway from a full stomach, our standard technique is a rapid sequence induction, or RSI. We paralyze and tube them as fast as humanly possible.
Right.
But the very stimuli associated with RSI, the stress of laryngoscopy, suctioning in the throat, the drugs themselves, can all raise IOP.
While to protect the eye, you'd want a gentle, slow, deep induction.
Precisely. But a slow induction leaves the airway unprotected for a dangerously long time in a patient with a full stomach.
It's the classic anesthetic catch-22.
It is. And the guiding principle, the phrase you must remember and even write in your exam, is life before eye. But the art and science of anesthesia is doing everything in your power to save both.
Okay, that's a very clear framework. So let's move into the practicalities. Preoperative considerations. Section 4. We're in the trauma bay. The patient has just arrived.
The first thing you do is zoom out. Don't get tunnel vision.
What do you mean?
Morgan's text emphasizes this really well. You must check for associated injuries. If a patient has a piece of metal in their eye from a grinder, did it go through the orbit and into the brain?
Oh, wow.
If they were in a car crash, do they have a cervical spine fracture? A pneumothorax?
Yeah.
Do not get so focused on the eye that you miss a ruptured spleen or a subdural hematoma.
So it's the standard ATLS approach first. ABC.
Always. Airway, breathing, circulation. You stabilize the patient first. Life before eye.
Okay, once we've cleared the major life threats, we focus on the eye. What's the next big assumption?
We assume full stomach, no exception.
Even if the patient or their family says, oh, he hasn't eaten in 8 hours.
Even then, trauma, pain, and the sympathetic overdrive from the injury all cause gastroparesis. They shut down the pylorus. So if they ate a big meal at noon and got injured at 1 p.m., and you're taking them to the operating theater at 8 p.m., that meal is very likely still sitting in their stomach.
So they are an aspiration risk, period.
Period.
What about their psychological state? The anxiety and the pain, does that affect the eye directly?
It's a huge factor, and it's one we can actually do something about. Anxiety and pain increase sympathetic tone. If the patient is thrashing around, crying, or straining, their central venous pressure, their CVP, is spiking.
And as you said, that venous pressure directly translates to choroidal swelling.
And a rise in IOP. So we need them calm.
Which brings us to premedication.
Yes, but you have to be very careful here. It's a fine line to walk.
So we want to give them something for anxiety, like midazolam.
A small dose of midazolam, yes, maybe 1 or 2 milligrams. Or a small dose of fentanyl for the pain. These are great tools, but, and here is the Viva trap, if you oversedate them,
They stop breathing properly,
they start hypoventilating, their respiratory rate drops,
and their CO2 goes up.
their CO2 goes up. And hypercarbia, high CO2 in the blood, is a potent cerebral and choroidal vasodilator. It dilates those blood vessels in the back of the eye and raises IOP.
So too much sedation is just as bad as not enough.
Exactly. You want a Goldilocks patient. Calm, comfortable, pain-free, but breathing normally and maintaining their airway.
Okay, this is all making sense. Now we're moving to the main event. Section 5. Induction of anesthesia. This is labeled very high yield. This is where the big debate lives.
This is it. The Succinylcholine controversy.
Let's unpack this slowly. The dogma versus the data.
Right. The traditional teaching, what you might find in older textbooks, what your older consultant might have sworn by, is that succinylcholine, or a SERE, is absolutely contraindicated in open globe injuries.
And the reasoning for that? Why?
Succinylcholine is a depolarizing muscle relaxant. It works by first activating the nicotinic receptors before it blocks them.
Which causes the muscle twitches, the fasciculations.
It causes fasciculations all over the body. It also causes a transient but significant tonic contraction of the extraocular muscles.
So the muscles that move the eye actually tense up.
They tense up and they squeeze the globe. The theory is that this contraction squeezes the eyeball like a hand squeezing a grape, raising the IOP by about 5 to 10 millimeters of mercury for a few minutes.
Which, in an open eye with no containment, sounds like a recipe for extrusion.
Theoretically, yes. It makes perfect physiological sense. And for a long time, that was the end of the story. Don't use it. But then we started looking at the actual data. Let's look at the big sources. Miller and Morgan both point this out very clearly. When you look at the large retrospective studies, the case reports, the clinical evidence, there are no confirmed cases of vitreous extrusion solely attributed to the use of succinylcholine.
Wait, 0 cases, none at all.
Basically zero. It appears to be a theoretical risk that, for whatever reason, has not played out in clinical reality. Now, you have to compare that small, transient, 5 to 10 millimeter of mercury rise from ESO
What?
to the rise caused by a patient coughing, gagging, or bucking on the tube because your alternative muscle relaxant didn't work fast enough or well enough.
And how much does a cough raise IOP?
A violent cough or a Valsalva maneuver can spike venous pressure and IOP by 40, 50, even 60 millimeters of mercury. It's an order of magnitude higher. It's catastrophic.
So the risk of a bad airway from a suboptimal intubation is much, much worse than the theoretical risk from succinylcholine.
Much worse. So for the exam, what's the faculty verdict? How do you answer this tricky question?
Okay, this is key.
If the examiner asks, "Doctor, do you use succinylcholine?" You need to give a nuanced answer. You say, "Ideally, with modern drugs available, I would choose an alternative like high-dose rocuronium. It avoids the issue entirely."
Okay, start with the ideal.
However, you continue, if I anticipate a difficult airway, or if I need to secure the airway with maximum speed and predictability, and rocuronium is not a suitable option, then succinylcholine is acceptable.
And you give the reason.
You give the reason, and you use this exact phrase. The guiding principle is, it is better to have a live patient with a blind eye than a dead patient with a saved eye.
That's the phrase to memorize. Live patient, blind eye.
It shows the examiner you understand risk stratification and you have your priorities straight. Airway first.
Okay, you mentioned the modern alternative, rocuronium. Let's talk about the modified RSI.
This is the modern standard of care in most places. Rocuronium is a non-depolarizing relaxant. It doesn't cause fasciculations. It doesn't raise IOP. In fact, it does nothing to IOP. It's perfect.
But there's a catch, right? It's slower.
At the standard intubating dose of 0.6 milligrams per kilogram, it can take 2 to 3 minutes to achieve full paralysis. That is far too long to wait with an unprotected airway in a full stomach patient.
So we just use more.
We use a lot more. We use what's called high-dose rocuronium. 0.9 to 1.2 milligrams per kilogram.
Doubled the dose.
At this dose, it works in 60 to 90 seconds. That's almost as fast as succinylcholine. It gives you perfect, profound intubating conditions without any of the risk to the eye.
Are there any downsides to this approach?
The main downside is the duration of action. A 1.2 milligram per kilogram dose will paralyze the patient for 50 to 60 minutes, sometimes longer.
So if you can't intubate.
If you get into a can't intubate, can't ventilate scenario, you are in serious trouble. You now have a completely paralyzed patient with a long-acting drug on board. You need to be very confident in your airway skills and ideally have the reversal agent Sugammadex available in the room.
That makes sense. What about the induction agent itself? Propofol versus thiopentone or ketamine?
Propofol is the gold standard for this right now. It's known to cause a significant drop in IOP, which is a great side effect for us here. It also blunts laryngeal reflexes better than the older drugs like thiopentone.
Thiopentone's still okay, though.
Thiopentone is the classic choice and is perfectly safe. It also lowers IOP, but most would agree propofol gives you a smoother ride.
And ketamine. You mentioned that's a Viva trap.
A huge Viva trap. Historically, ketamine was considered strictly contraindicated. It was thought to raise IOP, and it causes nystagmus, the rapid eye movements which surgeons hate.
But is that still true?
The evidence is a bit more nuanced now. Newer studies suggest the IOP rise is minimal if ventilation is properly managed and you avoid hypoventilation. But for your exam, unless the patient is in profound hemorrhagic shock and about to die from hypotension, you avoid ketamine. Stick to propofol or maybe etomidate if hemodynamically unstable. Don't offer ketamine as your first choice.
Got it. One last thing on induction. Cricoid pressure?
The Selleck maneuver. Yes. This is another controversial topic in general anesthesia with questions about its efficacy. But for an exam RSI protocol, you generally say you will use it.
But with a very important instruction.
A vital instruction. You must look at your assistant and say very clearly, apply cricoid pressure only. Watch the eyes. Do not put any pressure on the face or the globe.
Because it's easy for someone to lean in during a stressful intubation.
You would be surprised how often people inadvertently lean on the patient's face during a crisis. It has to be a conscious effort to avoid it.
Okay, that covers induction. Let's move to section 6. Airway management. We've induced, the patient is paralyzed, now we have to actually intubate.
The goal here is smooth laryngoscopy. The act of putting a metal blade into the throat is a massive stimulus. It's a noxious stimulus that causes a huge sympathetic surge.
Heart rate goes up, blood pressure goes up.
And IOP goes up. We need to blunt that reflex.
How do we do that?
There are a couple of key drugs. The most important one is probably IV lidocaine.
Lidocaine, the local anesthetic.
Yes, given intravenously. 1.5 milligrams per kilogram, given about 2 to 3 minutes before you attempt laryngoscopy. It has a wonderful effect of suppressing the cough reflex and blunting the hemodynamic response to the tube.
What else?
You'd also use a fast-acting opioid. A good dose of fentanyl, or even better, an infusion of remifentanil, will make the laryngoscopy much smoother.
And the tube itself? Any specific choice?
Ideally, you'd use an oral RAE tube, that's Ringidaire Elwyn, or a reinforced flexible tube.
And why is that?
Because the preformed bend in the RAE tube directs the connector and the breathing circuit down over the chin away from the surgical field. The surgeon needs clear, unobstructed access to the face and eyes. And of course, you secure it exceptionally well. No accidental extubations.
Okay. Section 7. Maintenance of anesthesia. We're in. The tube is secured. The patient is stable.
No, our job is to provide absolute stability and stillness. We use controlled mechanical ventilation.
No spontaneous breathing.
Absolutely not. We cannot allow the patient to breathe spontaneously because if they take a gasp or cough against a ventilator, the diaphragm moves, venous pressure changes, and the eye can move. We use a continuous infusion of a non-depolarizing muscle relaxant to ensure absolute akinesia.
And what about the CO2 level?
We aim for normocapnia. Keep the end tidal CO2 around 35 millimeters of mercury. You must avoid hypercarbia, as we said, because that causes vasodilation and high IOP.
It's good to aim for low CO2 then. Hypocarbia.
A little bit of hypocapnia can be helpful as it causes some vasoconstriction and can lower IOP slightly, but you want to avoid extreme hypocapnia because that can reduce cerebral blood flow, which is not ideal, especially in a trauma patient who might have a head injury. So normocapnia is the safest target.
Volatile agents like sevoflurane or Tefaiva with propofol. Any preference?
Both are excellent choices, and you could mention either in an exam. Volatile agents like sevoflurane are great and also have a mild IOP lowering effect. Tiva total intravenous anesthesia with a propofol infusion is perhaps more elegant.
Why elegant?
Because propofol provides a very stable, deep level of anesthesia and keeps the IOP consistently low throughout the entire procedure. It's a very smooth technique.
Okay, surgery is done. The eye is stitched up. The surgeon is happy.
Yeah.
We're safe. Right. Let's talk about Section 8, emergence and extubation.
Wrong. We are absolutely not safe. This is the danger zone. Extubation is arguably more dangerous and requires more skill than induction.
More dangerous. Why?
Coughing, bucking, straining. If the patient bucks or has a violent coughing fit on the endotracheal tube during wake-up, their venous pressure spikes to 40, 50, or even higher.
And that pressure is transmitted directly to the fresh suture line on the eye.
Exactly. That fresh, delicate suture line can rupture. You can get a wound dehiscence, or even worse, a suprachoroidal hemorrhage. The eye is lost in seconds. Everything you did for the last hour is undone.
So what do we do? In elective surgery, we might do a deep extubation to avoid coughing. Is that an option here?
In elective eye surgery in a fasted patient, yes. Deep extubation, pulling the tube out while the patient is still deeply anesthetized, is the smoothest way. But remember our patient.
Full stomach.
Full stomach. Deep extubation is generally considered contraindicated because the patient's protective airway reflexes are absent. If they regurgitate while deep, they will silently aspirate gastric contents into their lungs.
So we're stuck. We can't extubate them deep because of the aspiration risk, but if we wake them up with the tube in, they'll cough and destroy the eye.
We are between a rock and a hard place. This is where the skill comes in. We have to use what's called the smooth awake technique.
Okay, break that down for me step by step.
Step 1. Before you even think about reversing the muscle relaxant while they are still deep, you gently suction the pharynx to remove any secretions. You never suction when they are light, as that will provoke a cough.
Okay, gentle suction while deep.
Step 2. You administer another dose of IV lidocaine, 1.5 milligrams per kilogram, just like you did for intubation. This will help suppress the cough reflex during emergence.
Lidocaine again. Got it.
Step 3. You fully reverse the muscle relaxant. Ensure they have full power back. Step 4. Turn off the anesthetic agent. Step 5. You talk to them calmly and continuously as they wake up. The surgery's over. Everything went well. Open your eyes. Take a deep breath. Try not to cough.
And step 6, the actual extubation.
You extubate the moment they are following commands, like opening their eyes. But you try to catch that perfect window before the fighting the tube phase kicks in. It's a real high-wire act.
Wow. It sounds incredibly delicate.
It is. A couple other things. Keep the head of the bed slightly elevated to help with venous drainage from the head and eyes. And treat postoperative nausea and vomiting, PONV, aggressively before they wake up. Vomiting is just as bad as coughing for raising IOP.
Okay. That is a comprehensive look at the emergency. Let's all take a deep breath and completely switch gears. We're moving to Part C squint surgery.
Also known as strabismus surgery, a totally different world.
Very high yield. Why? It seems so much more routine.
It's high yield because it's the classic pediatric ophthalmic case. Strabismus, which is a misalignment of the eyes, needs to be corrected early in life, usually before age 5 or 6, to prevent the development of amblyopia, or lazy eye.
So our patient is no longer a 30-year-old trauma victim. Our patient is a 3-year-old.
A 3-year-old, a 4-year-old, so immediately you're being tested on all the challenges of pediatric anesthesia. Separation anxiety, difficult 5V access, a small airway, different drug doses.
But beyond just being a pediatric case, what's the specific anesthetic relevance here?
The specific anesthetic relevance lies in two very important, very testable phenomena: the oculocardiac reflex, OCR, and postoperative nausea and vomiting, PONV.
Okay, so let's list the goals. Section 10. Anesthetic goals in squint surgery.
It's a different list. Number 1 is still immobility. It's still microsurgery, so the eye can't move.
Makes sense.
Number 2 is hemodynamic stability, which is a code word for managing the oculocardiac reflex.
Okay.
Number 3 is aggressive PONV prevention. This is absolutely crucial for these cases. And number 4 is ensuring suitability for daycare surgery. These kids need to be able to drink and go home safely without vomiting.
A very different set of priorities. So Section 11, preoperative assessment.
You're doing a standard pediatric evaluation. Any signs of an upper respiratory tract infection and URTI. Loose teeth that could be dislodged during laryngoscopy. Fasting guidelines are strict for safety, but we try to minimize the starvation time to prevent dehydration and irritability in a small child.
And the anesthetic technique itself. Section 12. Airway choice is a big one.
It is. For an elective squint surgery in a fasted child with a normal airway, the laryngeal mask airway, LMA, is often preferred over the endotracheal tube, ETT.
That's the opposite of what you said for open globe, where the ETT was mandatory. Why the difference?
The reason is simple: the stomach status. The open globe patient has a full stomach and needs the definitive protection of a cuffed ETT. The squint surgery patient is fasted.
And what's the advantage of the LMA here?
The LMA is a supraglottic device. It's less stimulating. It causes less coughing and bucking on insertion, and crucially, much less coughing on removal. We want the smoothest possible emergence to reduce the risk of PONV and venous congestion.
So it's all about a gentle wake-up.
A gentle wake-up. Just make sure you use a flexible or reinforced LMA so it doesn't get kinked or dislodged when the surgical drapes are placed over the child's head.
Okay. Now for the big one. Section 13, the oculocardiac reflex. The outline says this is absolutely essential.
If you get asked about squint surgery in an exam, you will be asked about the OCR. There's a 100% chance. You need to be able to define it, describe the pathway, and manage it. You should be able to draw the reflex arc from memory.
Let's trace it then. It's a trigeminovagal reflex.
That's the key phrase, trigeminovagal. The afferent limb, the sensory part, is the trigeminal nerve, which is cranial nerve 5.
And the efferent limb, the action part,
is the vagus nerve, cranial nerve 10.
Okay, walk us through the steps. The surgeon puts a hook on an eye muscle and pulls. What happened?
Okay, step by step. 1. The surgeon applies traction to an extraocular muscle. And for a bonus point, you should know that the medial rectus is the most potent trigger.
Medial rectus, got it.
2. Stretch receptors in that muscle send signals flying down the short and long ciliary nerves. 3. Those nerves join up to become the ophthalmic division, V1, of the trigeminal nerve.
E1.
4. That signal goes to the Gasserian ganglion, and from there, it travels into the brainstem to the sensory nucleus of the trigeminal nerve, which is located near the floor of the fourth ventricle.
So that's the whole sensory pathway. The brain now knows the muscle is being pulled. What does it do about it?
This is the crossover. The signal then synapses with, or talks to, the motor nucleus of the vagus nerve, which is right next door in the brainstem.
And the vagus nerve gets activated.
The vagus nerve fires a powerful impulse down to the heart, specifically to the SA node.
And the result of that vagal stimulation is?
The classic presentation, bradycardia. A sudden, profound drop in heart rate. It can also cause a junctional rhythm, ectopic beats, or in the most severe cases, sinus arrest or systole.
A systole. The heart can actually stop.
Yes. It can cause a cardiac arrest. I've seen it happen. Just from the surgeon pulling on an eye muscle, it's a profoundly powerful reflex.
Okay, so management is critical. The examiner in the Viva says to you, the child's heart rate drops from 110 to 50. What is your first step?
Trap alert. This is a huge trap for junior residents. The knee-jerk answer is give atropine. That is the wrong answer.
So what's the right answer?
The first, second, and third step is stop the stimulus. You must immediately and clearly tell the surgeon, please stop, let go of the muscle.
And it usually works.
In 99% of cases, the moment the traction is released, the heart rate immediately recovers back to normal. It's dramatic.
And what if it doesn't? What if the bradycardia persists?
Then you go down your checklist. Step 2. Check your ventilation. Hypoxia and hypercarbia are known to potentiate or worsen this reflex. So make sure the airway is clear, you're delivering oxygen, and your CO2 is normal.
Good point.
Step 3. Check your depth of anesthesia. The reflex is much more active under light anesthesia, so you might need to deepen the sevoflurane a little.
And step 4 is the drugs.
Step 4. If the bradycardia is persistent or severe, like asystole, then you give IV atropine. The dose is 0.01 to 0.02 milligrams per kilogram.
What about giving atropine prophylactically before the surgery starts to prevent it?
That's a common practice, and it's a very reasonable thing to do, especially in small children who are naturally more vagal anyway. Many anesthetists will give atropine or glycopyrrolate on induction. But for the exam question about treatment, the #1 answer is always stop the stimulus.
You also mentioned in the outline that the reflex fatigues. What does that mean?
Yes, that's an interesting property. With repeated, gentle stimulation, the reflex response tends to weaken. This is important information to share with your surgeon. You can say, okay, the heart rate is back to normal. Let's try again, but please apply the traction more gently this time.
Okay, that is a very thorough explanation of OCR. Let's move to the other big problem in squint surgery. Section 14, PONV. The outline calls it an exam favorite.
It is. Squint surgery is widely considered to be one of the most, if not the most, immunogenic surgeries in pediatrics. Some people even call it the Oculogastric reflex.
What's the incidence? How common is it?
Without any prophylaxis, the incidence of PONV after squint surgery can be as high as 80%. 8 out of 10 kids will vomit.
That's astonishingly high. Why? What's the mechanism?
The theory is that the manipulation of the eye muscles and the disturbance to the vestibulo-ocular system essentially mimics the sensation of motion sickness. You're creating a mismatch between what the eyes and the inner ear are telling the brain. Add to that the fact that the pediatric age group is an independent risk factor, and so is the use of opioids for pain. It's a perfect storm for nausea.
So prophylaxis isn't optional. It's mandatory.
Multimodal prophylaxis is mandatory. You have to attack it from multiple angles with different drug classes. A single drug is not enough.
But what's the cocktail? What's in your multimodal recipe?
Okay, first you start with dexamethasone, a dose of 0.1 to 0.5 milligrams per kilogram given intravenously right after induction.
A steroid.
Second, at the end of the surgery, you give a 5-HT3 antagonist like ondansetron. The dose is 0.1 milligrams per kilogram.
So 2 different antiemetics. What else?
Third, and this is simple but effective, is adequate hydration. Dehydration is a big trigger for nausea, so ensure they get enough IV fluids during the case.
What about the anesthetic gases?
This is a bit debated, but for an exam answer, it's very safe to say you would avoid nitrous oxide. N2O is known to increase the risk of PONV, so in a highly immunogenic case like this, it's best to just leave it out and use an neuroxygen mixture.
And what about pain relief? You mentioned opioids are a problem.
This is key. You want an opioid-sparing technique. That means relying on non-opioid analgesics. So giving IV paracetamol or an NSAID like ketorolac. Some surgeons might even perform a subtenons block with local anesthetic, which provides excellent pain relief without systemic opioids, although that's more common in adults than kids.
Okay, that brings us to the end of Part C. Let's move to Part D, Complications and Management. Sections 15 and 16. We've touched on most of these already, but let's just crystallize them for an exam answer.
Good idea. For open globe, the big 3 complications are:
Number 1.
extrusion of ocular contents. This is caused by any sudden rise in IOP coughing, straining the theoretical risk from ESH. The result is catastrophic, permanent blindness.
Number 2.
Aspiration pneumonitis. This is caused by the full stomach status. If you don't protect the airway properly, the result can be severe pneumonia, ARDS, and even death.
And number 3.
Failed intubation. This is the ultimate anesthetic crisis during an RSI. It leads to hypoxia, hypercarbia, and the patient straining against your attempts, all of which compound the eye injury.
And for squint surgery, the complications are different.
Completely different list. Number 1 is the most acute and dangerous, a severe oculocardiac reflex, leading to profound bradycardia or a systole.
Number 2 is the most common.
Postoperative nausea and vomiting. This isn't usually life-threatening, but it causes significant distress and can lead to dehydration and an unplanned hospital admission in a daycare case.
And there's one more you mentioned, a rare but classic association.
Malignant hyperthermia, MH. This is a key deep dive point to impress an examiner. There is a known statistical association between congenital musculoskeletal disorders like strabismus and ptosis and underlying myopathies like central core disease, which are strongly linked to MH susceptibility.
So if you're doing a long list of squint cases,
You need to have a high index of suspicion. Watch your end-tidal CO2 like a hawk. If it starts rising unexpectedly and the patient becomes tachycardic and rigid, you must consider MH as a diagnosis.
okay, that's a perfect summary of the risks. Now for Part E, comparison and exam integration, this is where we bring it all home and structure it for the win. Section 17, the comparison table.
This is a fantastic way to end a long answer question. You can literally draw 2 columns in your answer booklet, open globe versus squint.
Let's run through the rows. Row 1, urgency.
Open globe is a true emergency. Squint is elective.
Row 2, stomach status.
Open globe, assume full stomach. Squint, assumed fasted, NPO.
Row 3, airway management.
Open globe, mandatory RSI with an ETT. Squint. LMA is often preferred, though an ETT is also acceptable.
Row 4,
Wow.
the main physiological goal or fear.
For open globe, it's all about controlling IOP and preventing extrusion. For squint, it's all about controlling vagal tone and preventing the OCR.
And the last row, extubation strategy.
Open globe, a careful, smooth awake extubation. Squint. Deep extubation is often ideal, or a very smooth awake one.
Perfect. Section 18, Viva traps. We've covered the big Succinylcholine one. What other traps might an examiner set?
Okay, here's another classic. Trap number 1, the regional block. The examiner says, "Doctor, your open globe patient is 85 years old and has severe COPD. Why not avoid a risky GA and just do a retrobulbar block for the surgery?"
And the answer is?
A retrobulbar block is an absolute contraindication in an open globe injury. Because to perform the block, you have to inject about 5 milliliters of local anesthetic behind the eyeball into the muscle cone. You're adding volume to that closed compartment. This pushes the globe forward and dramatically increases pressure, which will squeeze the contents out of the open wound. You never inject behind an open eye.
That's a great point. What's another trap?
Trap number 2, the gas bubble. The examiner says the surgeon is performing a vitrectomy as part of the repair and is about to inject SF6 gas into the eye. Can you continue using nitrous oxide?
And the answer there is a firm no.
A firm no. You have to explain why. Nitrous oxide is much more soluble than nitrogen. It will diffuse from the bloodstream into that gas bubble inside the eye much faster than the nitrogen in the bubble can diffuse out.
So the bubble expands.
Rapidly and dramatically. It expands and can raise the IOP to dangerous levels, causing a central retinal artery occlusion, blindness. You must turn off the nitrous oxide at least 15 minutes before any intraocular gas injection.
Excellent. Section 19, diagrams and exam presentation. If I have time in the exam, what should I draw?
2 diagrams will get you maximum marks. First, the OCR pathway. Practice drawing the simple loop. The eye, the trigeminal nerve going to the brainstem, the synapse, and the vagus nerve going to the heart. Label V and X. It shows you understand the mechanism.
And the second diagram.
A simple bar chart showing the factors affecting IOP. Have a small bar for arterial pressure, a medium bar for venous pressure, and then a massive bar for vomiting or coughing. It visually demonstrates where the real danger lies.
That's a great tip. Finally, Section 20, summary and exam conclusion. Give us the 15-second elevator pitch, the model paragraph to end our exam answer.
Okay, here it is. You're right. In summary, the anesthetic management of ophthalmic surgery requires a highly tailored approach based on the specific pathology and urgency of the procedure.
Good start.
For an open globe injury, the primary challenge is balancing the conflicting demands of airway protection, requiring a rapid sequence induction, with the absolute necessity of strict IOP control to prevent vitreous extrusion. The principle of life before eye must guide all decisions.
And for Squint,
Conversely, in elective squint surgery, the focus shifts to the unique challenges of pediatric anesthesia, including profound vigilance for the trigeminal oculocardiac reflex and the implementation of an aggressive multimodal prophylactic strategy to combat the high incidence of postoperative nausea and vomiting.
And a final sentence to tie it all together.
Ultimately, success in both scenarios lies in the anesthetist's ability to anticipate these specific physiological conflicts and manage them proactively to ensure both patient safety and the preservation of vision.
Fantastic. That is a distinction-level answer right there.
It covers all the key points.
We have gone incredibly deep today, from the physics of the choroid all the way to the specific receptors of the neuromuscular junction.
It's a lot of information, I know. But if you can just stick to those core principles, like before eye, stop the stimulus, smooth emergence, you'll be able to reason your way through any question they throw at you.
Well, good luck to everyone out there preparing for the Gujarat University exams, or any board exam for that matter. Visualize that reflex arc, remember the data on Succinylcholine, and go in there with confidence.
You'll do great.
Thanks for listening to The Deep Dive.
Good luck.